Tonight we explore how the human body can produce real, measurable changes in response to nothing more than an expectation. You've probably had this experience. You swallow a pill for a headache. Within a few minutes, the pain begins to soften. But here's what's strange. Most oral medications take 20 to 30 minutes to dissolve, absorb through the stomach lining, enter the bloodstream, and reach the brain. The relief you felt after 5 minutes wasn't the drug. It was you. Your brain, registering the act of swallowing a pill, began adjusting its own chemistry before the active ingredient had even left your stomach. This is the placebo effect, and it is not a trick. It is not weakness. It is not imagination in the way most people understand that word. It is a measurable, reproducible biological response, where the expectation of healing activates the same neural circuits and chemical pathways that actual treatments use. The word placebo comes from Latin. It means, "I shall please." The term first appeared in medical literature in the late 18th century, used to describe treatments given more for the comfort of the patient than for any proven medical value. For a long time, it carried a sense of dismissal. A placebo was something you gave when you had nothing real to offer. But over the past 70 years, researchers have discovered that placebos are not empty. They trigger the release of endorphins. They alter dopamine levels. They change heart rate and blood pressure. They shift immune cell counts. These are not subjective feelings written on a questionnaire. These are physical changes visible in blood draws and brain scans. Across this video, you'll gradually learn how this works. We'll move through 100 observations slowly, one at a time, covering the history, the chemistry, the surprises, and the quiet implications of a body that heals partly because it believes it will. There's no rush. Let each fact settle. Let the ones that interest you stay. Let the rest drift past like slow clouds in a night sky. We begin where much of modern placebo science began, on a battlefield in the middle of the Second World War. In 1944, an American anesthesiologist named Henry Knowles Beecher was stationed at a field hospital near the Anzio beachhead in Italy. Wounded soldiers arrived in waves. Morphine supplies ran low. Beecher faced a decision no doctor wants to face: soldiers in pain, and no painkiller left to give them. A nurse at the hospital injected saline solution, salt water, into several soldiers, telling them it was morphine. What happened next changed Beecher's understanding of medicine. Many of those soldiers reported significant pain relief. Their bodies relaxed. Their breathing steadied. Some fell asleep. Beecher was a careful observer. He didn't dismiss what he saw. He carried the memory of those injections back with him after the war, and he spent the next decade studying what had happened on that beach. In 1955, Beecher published a paper called "The Powerful Placebo" in the Journal of the American Medical Association. In it, he reviewed data from 15 clinical studies involving over 1,000 patients. His conclusion was direct. Roughly 35% of patients across these trials responded to treatments that contained no active ingredient at all. That number, 35%, entered the medical literature and stayed there for decades. Later researchers questioned his methods and adjusted his estimates. Some argued the real figure was lower. Others found it was higher, depending on the condition. But the core observation held. A large number of patients improved when given nothing but the appearance of treatment. Beecher wasn't the first person to notice this pattern. He was just the first to measure it systematically and published the results in a major journal, but others had seen it long before him. In the late 1700s, a device called Perkins tractors became popular across England and parts of America. These were small metallic rods, about 3 inches long, made from specific alloys. Their inventor, Elisha Perkins, claimed that drawing the rods across the skin could cure headaches, joint pain, and inflammation. He patented the device in 1796. People paid 5 guineas for a pair, a large sum at the time. A physician named John Haygarth grew skeptical. In 1799, he conducted one of the earliest controlled experiments in medical history. He made fake Perkins tractors out of wood and bone, painted to look identical to the originals. Then he tested both versions on patients at the Bath General Hospital. The results were clear. The wooden fakes worked just as well as the metal rods. Patients reported the same relief, the same warmth, the same reduction in pain. Haygarth published his findings in a short book with a long title of The Imagination as a Cause and as a Cure of Disorders of the Body. That phrase, the imagination as a cause and as a cure, was written in 1800. It took medicine another 150 years to take the idea seriously. Before Haygarth and Beecher, physicians across many centuries used treatments we would now call placebos, though they didn't use the word. Bread pills were common in the 18th and 19th centuries. Doctors prescribed them knowing they contained no active substance. The pills were given to satisfy a patient's expectation that a doctor should provide medicine. The term placebo entered the medical dictionary in 1811, defined by Hooper's Medical Dictionary as an epithet given to any medicine adapted more to please than to benefit the patient. Notice the word please. The Latin root shows through. The assumption was that pleasing the patient and benefiting the patient were separate acts. That assumption turned out to be wrong. The modern placebo-controlled trial emerged gradually through the early 20th century. In 1943, a study on the common cold used lactose tablets as a control. In 1947, the British Medical Research Council conducted a randomized controlled trial of streptomycin for tuberculosis, one of the first to use a formal control group. By the 1960s, the U.S. Food and Drug Administration required that new drugs prove their effectiveness against a placebo before approval. This regulatory shift was enormous. It meant that every new medication had to outperform the body's own response to expectation, and that turned out to be a high bar. Some drugs barely cleared it, others didn't clear it at all. The placebo arm of clinical trials sometimes showed improvement rates of 40, 50, even 60%, depending on the condition being treated. Researchers began to realize that the placebo wasn't just a blank control. It was an active process. Something real was happening in those patients, and it was happening in the brain. In the 1960s and 1970s, researchers began asking a question that would have seemed strange a generation earlier. What if the placebo effect isn't about nothing? What if it's about something specific happening inside the nervous system? The answer came in stages, and it started with pain. In 1978, a team led by John Levine, Newton Gordon, and Howard Fields at the University of California, San Francisco conducted an experiment that changed the field. They studied patients who had just undergone dental surgery, wisdom tooth extraction. After surgery, some patients received a placebo painkiller. Many of them reported significant pain relief. Then the researchers did something clever. They gave those same patients naloxone, a drug that blocks opioid receptors in the brain. Naloxone is the drug paramedics carry to reverse heroin overdoses. It works by physically preventing opioid molecules from binding to their receptors. When naloxone was administered, the placebo pain relief vanished. The patient's pain came back. This was a landmark finding. It meant the placebo wasn't just changing how people reported their pain. It was triggering the release of real opioid molecules, endorphins, inside the brain. And when those molecules were blocked, the effect disappeared. The body was manufacturing its own painkillers in response to a belief. Fabrizio Benedetti, a neuroscientist at the University of Turin in Italy, spent much of his career expanding on this discovery. His experiments, conducted over more than 2 decades, mapped the specific chemical pathways involved in different types of placebo responses. Benedetti showed that placebo analgesia, pain relief from an inert treatment, could be blocked by naloxone, confirming it ran through opioid pathways. But he also found something else. Not all placebo responses used opioids. When patients expected relief from a non-opioid mechanism, for example, when they were told the treatment worked through anti-inflammatory pathways, the response didn't depend on opioids at all. Different expectations activated different chemical systems. The brain wasn't running a single placebo program. It was selecting the appropriate chemical response based on what the patient believed was happening. This is worth sitting with for a moment. The brain doesn't just release a generic feel-good chemical when you expect to feel better. It releases specific molecules through specific pathways, matched to the type of relief you expect. If you expect opioid-like pain relief, your brain sends endorphins. If you expect something different, your brain finds a different route. Dopamine enters the picture in a different way. In the early 2000s, Raul de la Fuente Fernandez and his colleagues at the University of British Columbia studied patients with Parkinson's disease. Parkinson's involves the progressive loss of dopamine-producing neurons in a region of the midbrain called the substantia nigra. Patients experience tremors, stiffness, and difficulty initiating movement. The researchers gave Parkinson's patients a placebo injection and told them it was a real anti-Parkinson's medication. Then they measured dopamine levels in the brain using positron emission tomography, PET imaging. Dopamine release in the nucleus accumbens increased, not by a small amount. The increase was comparable to what you'd see with a dose of amphetamine, a drug that directly forces dopamine release. The patient's brains responded to the expectation of medication by producing the very chemical the medication was designed to replace. And the effect wasn't just chemical. Many patients showed temporary motor improvements. Their hands steadied. Their movements became more fluid. This didn't last. The placebo couldn't replace the function of dying neurons over the long term, but for a window of time the brain compensated, through expectation alone. The prefrontal cortex plays a central role in generating these responses. This region, located behind the forehead, is involved in planning, decision-making, and the generation of predictions about future events. During placebo responses, the prefrontal cortex sends signals downward, what neuroscientists call top-down modulation, to regions in the brain stem and spinal cord that process pain signals. One of those regions is the periaqueductal gray, a small structure deep in the midbrain. The periaqueductal gray is part of the brain's built-in pain suppression system. When activated, it releases endogenous opioids that dampen incoming pain signals before they reach conscious awareness. The prefrontal cortex effectively tells the periaqueductal gray pain relief is coming. Start shutting down the alarm, and the alarm quiets. This is the same system that activates during the stress of combat, during intense athletic competition, during moments when the body decides that feeling pain would be a disadvantage. The placebo taps into a system that evolution built for survival. Functional MRI studies have shown these changes in real time. When a person receives a placebo they believe is a painkiller, activity decreases in pain processing regions like the thalamus, the anterior insula, and the somatosensory cortex. Activity increases in the prefrontal cortex and the rostral anterior cingulate cortex, regions involved in emotional regulation and expectation. The brain literally turns down the volume on pain signals, not metaphorically. The electrical activity in pain processing regions measurably decreases. And it does this without any external chemical entering the body. Endocannabinoids, the brain's own cannabis-like molecules, also participate in certain placebo responses. Benedetti's group found that when placebo analgesia was induced through a non-opioid mechanism, it could be blocked by rimonabant, a drug that blocks cannabinoid receptors. This meant the brain was using its endocannabinoid system as an alternative route for pain suppression. The brain has multiple pain relief systems: opioid pathways, cannabinoid pathways, descending inhibitory circuits. The placebo effect doesn't invent a new mechanism. It activates mechanisms that already exist, using expectation as the trigger instead of a drug. Cholecystokinin, a peptide usually associated with digestion, also plays a role, but on the opposite side. Cholecystokinin, often abbreviated as CCK, is involved in amplifying pain and anxiety. When a person expects pain to increase, CCK levels rise. This is part of the nocebo effect, which we'll reach later. For now, just notice the symmetry. The brain has chemical systems for turning pain down and chemical systems for turning pain up. Expectation can activate either one. Oxytocin, the molecule often associated with bonding and trust, has been shown to enhance placebo responses in social contexts. When patients feel trusted and cared for by a physician, oxytocin levels may increase and placebo responses become stronger. The chemistry of trust feeds directly into the chemistry of healing. Serotonin pathways appear to be involved in placebo responses to antidepressants. Patients who respond to placebo in depression trials show changes in serotonin receptor binding in brain regions associated with mood regulation. The brain adjusts its own serotonin signaling in response to the expectation of improvement. These are not vague or general effects. They are specific chemical changes in specific brain regions, measurable with specific imaging techniques, and they happen reliably across dozens of studies in labs all over the world. These early observations describe how placebo signals move through the brain's chemical systems. The next group of facts looks at how these signals change the body itself. The placebo effect does not stop at the boundary of the brain. It reaches into the body. Heart rate changes, blood pressure shifts, gastric acid secretion adjusts, immune cells alter their behavior. These are not feelings. They are physiological events measurable with standard medical equipment. In clinical trials for hypertension, patients given placebo pills show reductions in blood pressure, not as large as the reductions seen with active medication typically, but measurable, consistent, real. The brain, expecting a blood pressure medication, sends signals through the autonomic nervous system that dilate blood vessels and slow the heart. In studies of gastric ulcers, placebo treatment produced healing rates as high as 30 to 40% in some trials. The mucous lining of the stomach actually regenerated. Endoscopy confirmed the changes. This wasn't patients saying they felt better while their ulcers remained. The tissue healed. Placebo responses affect the immune system in measurable ways. In conditioning experiments, researchers paired a distinctively flavored drink with cyclosporin, an immunosuppressant drug. After several pairings, the drink alone, without any drug, produced a measurable suppression of immune markers. T-cell activity decreased. Interleukin-2 production dropped. The immune system had learned to associate the taste with suppression, and it responded accordingly. This is classical conditioning, the same mechanism Pavlov demonstrated with dogs and bells in the 1890s. But instead of salivation, the conditioned response is immunosuppression. The body learned to turn down its own immune defenses in response to a flavor. In asthma research, the placebo effect shows a particular split between subjective and objective measures. Patients given inert inhalers, devices that delivered no active medication, frequently reported improved breathing. They felt less chest tightness. They felt they could breathe more deeply. But when researchers measured forced expiratory volume, the actual amount of air a patient could push out of their lungs in 1 second, the numbers didn't change. The lungs weren't working differently. The brain was interpreting the same lung function as less distressing. This distinction matters. The placebo changed the experience of breathing without changing the mechanics of breathing. And for a person lying awake at night feeling short of breath, the experience is what determines whether they sleep or stay awake in distress. One of the most striking placebo findings comes from orthopedic surgery. In 2002, Bruce Moseley, an orthopedic surgeon at the Baylor College of Medicine in Houston, published the results of a trial that challenged assumptions about one of the most common surgical procedures in the country, arthroscopic knee surgery for osteoarthritis. Moseley divided patients into 3 groups. One group received standard arthroscopic lavage. The joint was flushed with saline. A second group received arthroscopic debridement. Damaged cartilage was trimmed and removed. The third group received sham surgery. They were wheeled into the operating room. They received anesthesia. The surgeon made 3 small incisions in the skin, but no instruments entered the joint. No lavage, no debridement. The incisions were closed and the patient was sent to recovery. All 3 groups improved. And here's what mattered. The sham surgery group improved just as much as the 2 real surgery groups. At every follow-up point over 2 years, the outcomes were statistically indistinguishable. Patients who received no actual surgical repair walked better, reported less pain, and described greater satisfaction with their knees. The ritual of surgery, the consultation, the hospital visit, the anesthesia, the incisions, the recovery, produced the same result as the procedure itself. This study was controversial. Surgeons pushed back, but it was replicated and extended. A Finnish trial published in 2013 by Rain Sivvonen and colleagues found similar results for arthroscopic partial meniscectomy, another common knee procedure. Sham surgery performed equally well. The physical details of a placebo influence its strength. This is one of the more peculiar aspects of the effect. Larger pills produce stronger placebo responses than smaller pills. Two pills work better than one. Capsules outperform tablets. Injections outperform pills. And sham surgeries outperform injections. There seems to be a hierarchy of perceived intervention. The more dramatic, invasive, or elaborate the treatment ritual, the stronger the brain's response. A surgery carries more weight than a shot, which carries more weight than a pill, which carries more weight than being told to rest and wait. Color matters too. Blue placebo pills are better sedatives. Red pills are better stimulants. This has been documented in multiple studies. When patients receive a blue sugar pill and are told it will help them relax, they report more relaxation than patients who receive the same sugar pill in a red coating. The brain uses every available cue, shape, color, size, method of delivery to construct its prediction of what the treatment will do. Price affects placebo strength. In a study by Dan Ariely and colleagues, patients given a placebo painkiller described as costing $2.50 per pill reported more pain relief than patients given the same placebo described as costing 10 cents per pill. The expensive pill worked better, not because of any chemical difference, because the brain assigned greater value and greater expected efficacy to the expensive treatment. Brand names outperform generic labels on placebo pills. When the same inert substance is presented in branded packaging versus plain packaging, the branded version produces stronger effects. The brain reads marketing signals as medical signals. Even the route of administration shifts the response. Intravenous placebo saline produces stronger effects than subcutaneous injections, which produce stronger effects than oral placebos. The closer the delivery method comes to what patients associate with powerful medicine, the stronger the placebo effect becomes. The weight and texture of a pill contribute too. A heavier tablet feels more substantial. It feels like it contains more of something. And that feeling, registered almost below the level of conscious thought, feeds into the brain's prediction machinery. These details sound almost absurd when listed together. Pill color, pill size, price tags, packaging. None of these things should matter if the effect were purely pharmacological. But the placebo effect is not pharmacological. It is neurological. It runs on prediction, pattern recognition, and learned association. And the brain is very good at extracting predictions from small cues. Now we arrive at the placebo's shadow. Not all expectations point toward healing. Some point toward harm. The nocebo effect is the mirror image of the placebo effect. Where the placebo produces positive outcomes from positive expectations, the nocebo produces negative outcomes from negative expectations. Same mechanism, opposite direction. The word nocebo comes from Latin as well. It means I shall harm. It was coined in 1961 by Walter Kennedy to describe situations where an inert substance produces harmful effects because the patient expects harm. The nocebo effect is not rare. It is common, and in clinical settings it creates real problems. When patients are given a list of possible side effects before starting a new medication, as required by informed consent laws, a significant percentage of those patients will develop those exact side effects, even when they are taking the placebo arm of the trial. They weren't given the drug. They were given a sugar pill, but they were told the drug might cause nausea, headaches, or fatigue, and their bodies produced nausea, headaches, or fatigue. In a study conducted in Italy, patients undergoing treatment with a beta blocker were divided into two groups. Both groups received the same drug, but one group was told extensively about possible sexual side effects, erectile dysfunction, decreased libido. The other group was not given this information. In the group warned about sexual side effects, 32% reported problems. In the group that received no warning, only 13% reported the same problems. Same drug, same dose, different information, different outcome. A 2007 study by Reif and colleagues analyzed data from clinical trials of statins, cholesterol-lowering drugs taken by millions of people worldwide. They found that patients in the placebo groups who were informed about potential muscle pain reported muscle pain at elevated rates. The information created the symptom. In one experiment at a German university, healthy volunteers were told they would receive a mild electric current to the head. They were warned it might cause a headache. No current was delivered. The electrodes were inactive, but more than 2/3 of the participants reported headaches. The nocebo effect has a distinct neurochemistry. While the placebo analgesic effect runs largely through opioid and endocannabinoid pathways, the nocebo hyperalgesic effect, where pain increases, involves cholecystokinin, a peptide that amplifies pain signaling and increases anxiety. Benedetti's group showed this directly. When they induced nocebo hyperalgesia in volunteers, by telling them a previously painless stimulus would now be painful, CCK levels rose. When they administered proglumide, a drug that blocks CCK receptors, the nocebo effect diminished. The negative expectation was driving a specific chemical cascade, just as the positive expectation drove a different one. The anterior cingulate cortex lights up during nocebo responses. This brain region is involved in threat detection, error monitoring, and anxiety. It's part of the system that evaluates whether something might be wrong and alerts the rest of the brain to prepare for trouble. The hippocampus contributes too. This region, critical for memory formation, stores associations between past experiences and outcomes. If you once felt nauseous after taking a particular type of pill, your hippocampus remembers. The next time you take a similar pill, it feeds that association to the prefrontal cortex, which generates a prediction: this pill will make you nauseous. And the body complies. Nocebo effects can spread socially. In what researchers call mass psychogenic illness or mass sociogenic illness, groups of people develop symptoms, fainting, nausea, dizziness, headaches, not from any toxin or pathogen, but from the spread of expectation and anxiety through a community. A person sees someone else become ill and begins to expect that they will become ill too. The expectation produces the symptoms. In 1998, a teacher in a Tennessee high school noticed a gasoline-like smell in her classroom and developed headaches and nausea. She was taken to the hospital. Within hours, over 100 students and staff reported similar symptoms. The school was evacuated. Environmental testing found no toxic substances. The symptoms spread through expectation and social contagion. The nocebo effect creates a genuine ethical dilemma in medicine. Doctors are required to inform patients about potential side effects. That's the law, and it exists for good reason. Informed consent is a cornerstone of medical ethics. But the act of listing side effects can directly cause those side effects in a subset of patients. Some physicians have experimented with what's called contextualized informed consent, framing side effect information in ways that minimize nocebo responses. Instead of saying, "This drug may cause nausea," a doctor might say, "Most patients tolerate this drug well, though a small number experience mild nausea that typically resolves quickly." The information is the same. The framing is different, and the framing changes the outcome. Nocebo effects have been documented in cancer treatment. Patients receiving chemotherapy who are warned extensively about nausea experience more severe nausea than patients who receive less detailed warnings. This is complicated by the fact that chemotherapy genuinely does cause nausea through direct pharmacological mechanisms. The nocebo effect amplifies the already existing side effect. Withdrawal symptoms from placebos have been observed. In long-term clinical trials, patients who are switched from active medication to placebo sometimes experience withdrawal symptoms. But patients who were on placebo the entire time and are then told their treatment is ending also sometimes report withdrawal-like symptoms. Their brains had adapted to the ritual of taking the pill and now responded to its removal. The nocebo effect can persist through conditioning, just as positive placebo responses can be conditioned, paired with external cues, until the cues alone trigger the response. Negative nocebo responses can be conditioned too. A patient who once vomited in a specific room may feel nauseous upon returning to that room, even years later. The brain is an association machine, and it does not distinguish between associations that help and associations that harm. Pain researchers distinguish between two components of pain: the sensory component, which is the raw signal traveling up the nerves, and the affective component, which is the emotional distress the pain causes. Nocebo effects tend to amplify the affective component more than the sensory component. The pain doesn't necessarily get physically stronger. It gets more distressing, more threatening, more present. This is consistent with what we know about the brain regions involved. The anterior cingulate cortex and the anterior insula, both activated during nocebo responses, are primarily involved in the emotional processing of pain, not the detection of pain intensity. One of the quiet implications of nocebo research is that the medical environment itself, the white walls, the hospital smell, the sounds of machines, can become conditioned nocebo cues for patients who have had negative medical experiences. Walking into a hospital can make some people feel ill, not from infection, not from anxiety alone, from a conditioned physiological response that their brain has learned over repeated visits. This extends to the sounds of medical equipment, the beeping of a heart monitor, the hum of fluorescent lights in a treatment room, the snap of a latex glove. Each of these can serve as a conditioned stimulus that activates stress responses and symptom amplification in patients with extensive medical histories. And the nocebo effect works in reverse, too. When patients are told a procedure will not be painful, they report less pain, even when the procedure is objectively the same as one described as painful to a different group. The words a clinician chooses are not decoration. They are active ingredients. These observations about nocebo responses lead naturally to one of the more surprising findings in placebo science. Something that seems, at first, like it shouldn't work at all. What happens when you tell someone they're getting a placebo? What happens when there's no deception, no hidden sugar pill, no pretense that the treatment is real? The intuitive answer is that it shouldn't work. If the whole point of a placebo is that you believe it's real medicine, then knowing it's fake should cancel the effect. This makes logical sense. It also turns out to be wrong. Ted Kapchuk is a professor at Harvard Medical School. He spent years studying placebo effects, and he became uncomfortable with the ethical tensions of deceptive placebos. So he designed a trial to test whether placebos could work even when patients knew exactly what they were taking. In 2010, Kapchuk and his colleagues published the results of an open-label placebo trial for irritable bowel syndrome, IBS. Patients were divided into two groups. One group received no treatment. The other group received pills clearly labeled placebo. The bottle said placebo. The researcher told patients in plain language that the pills contained no active ingredient. Patients were also told that placebo effects are powerful and that the body can respond to the act of taking a pill even without an active drug. The patients who took the open-label placebos showed clinically meaningful improvement in their IBS symptoms compared to the no-treatment group. They knew the pills were inert. They took them anyway, and they felt better. This has been replicated across multiple conditions. Open-label placebos have shown positive effects in chronic low back pain, cancer-related fatigue, allergic rhinitis, and menopausal hot flashes. Not in all patients, not with the same magnitude as active drugs, but consistent, statistically significant improvements over no treatment. How is this possible? Several explanations have been proposed, and they're not mutually exclusive. One explanation centers on conditioning. Even when a patient knows a pill is inert, the physical act of swallowing a pill is associated with thousands of previous experiences of taking real medicine. The brain has learned, over a lifetime, that pill swallowing leads to feeling better. That conditioned association doesn't vanish just because the conscious mind knows the pill is a placebo. Conditioning operates below the level of conscious belief. Another explanation involves the therapeutic ritual. The act of visiting a researcher, receiving a consultation, being given a treatment, even one labeled as placebo, activates circuits associated with care, attention, and social support. The brain responds to being cared for. It responds to the structure and attention of a medical encounter. The pill is just one part of a larger ritual. Kapchuk has spoken about this extensively. He points out that healing has always involved ritual long before modern pharmacology existed. The shaman's chant, the healer's touch, the specific herbs ground in a specific way at a specific time. These rituals activated the brain's own healing mechanisms. Modern medicine stripped away the ritual and focused on the molecule. Open-label placebos suggest the ritual still matters. A third explanation is narrative. When patients are told, placebo effects are real and your body can respond to this pill even though it has no drug in it, they're given a story, a framework, an explanation that makes the act of taking a placebo feel coherent rather than absurd. And the brain responds to coherent narratives. We are narrative creatures. When an action makes sense within a story, the brain commits to it more fully. The doctor-patient relationship shapes placebo response strength in ways that have been measured directly. Kapchuk's group ran a trial comparing three conditions: a waiting list, a sham acupuncture treatment delivered with minimal interaction, and the same sham acupuncture treatment delivered with a warm, empathetic consultation. The warm consultation produced the largest improvement, not because the acupuncture was different, but because the human interaction was different. The warmth of a clinician's voice measurably changes patient outcomes. Eye contact matters. The amount of time spent listening matters. A doctor who sits down during a consultation produces different placebo responses than a doctor who remains standing. These are small differences in behavior that translate to measurable differences in symptom reports, pain ratings, and patient satisfaction. This shouldn't surprise us if we think about it in evolutionary terms. For most of human history, healing happened in a social context. A sick person was attended to by a group member, a healer, a relative, a caretaker. The brain evolved to interpret social attention and care as signals that recovery was underway. Someone is helping me is, from the brain's perspective, useful information. It means resources are being directed towards survival. And the brain responds by mobilizing its own recovery mechanisms. In the absence of social attention, when a patient feels ignored, dismissed, or anonymous, the placebo effect weakens, and nocebo effects may strengthen. The brain interprets the absence of care as a threat signal. No one is helping. The situation must be worse than expected. The therapeutic encounter is not separate from the treatment. It is part of the treatment. The consultation room, the clinician's attention, the ritual of examination and diagnosis, all of these feed into the same predictive machinery that generates placebo and nocebo responses. Consider what happens when a doctor prescribes a medication and says, "This should help you feel better within a few days." That sentence is not just information. It is an instruction to the brain's prediction system. It sets up an expectation. And the brain, receiving that expectation from a trusted authority figure in a medical setting, begins adjusting its internal state accordingly. Now consider what happens when a doctor prescribes the same medication and says, with visible uncertainty, "We can try this, but I'm not sure it will work." The prediction changes, the expectation weakens, and the placebo component of the treatment, which contributes to the overall effect of even active medications, diminishes. Every active drug has a placebo component. When you take ibuprofen for a headache, the relief you feel is partly pharmacological and partly placebo. The molecule reduces inflammation, but the act of taking the pill, the expectation of relief, the learned association between ibuprofen and pain reduction, all of these contribute to the total effect. Studies that compare open versus hidden administration of drugs show this clearly. In hidden administration studies, patients receive medication through an IV pump controlled by a computer. They don't know when the drug is being delivered. There's no ritual, no pill, no doctor saying this will help. Under these conditions, many drugs are less effective than when given openly by a clinician. The same drug, the same dose, the same route of administration, but less effect because the expectation component is missing. Morphine given openly provides more pain relief than morphine given covertly. The same molecule, working on the same receptors, produces a different outcome depending on whether the patient knows they're receiving it. The knowledge is not a bonus. It is part of the mechanism. This is true for anxiolytics too. Diazepam, Valium, reduces anxiety more effectively when the patient knows they're taking it. Given covertly, its effect is blunted. The expectation of calm contributes to the calm itself. These findings about ritual and expectation lead us to a broader view. How placebo responses vary across conditions, across populations, and across cultures. Placebo response rates in antidepressant clinical trials have been rising for 3 decades. In the 1980s, placebo response rates in major depression trials averaged around 30%. By the 2010s, they had risen to 40% or higher in many trials. This is a problem for pharmaceutical companies trying to develop new antidepressants, because the higher the placebo response, the harder it is for an active drug to demonstrate superiority. Why the increase? Several factors likely contribute. Trials have grown larger and more publicized. Patients who enroll in antidepressant trials today may have higher expectations of benefit. The cultural awareness of antidepressants has increased. People believe these drugs work, and that belief elevates the placebo response. Recruitment practices may also select for patients more likely to respond to placebo. And the clinical attention provided during a trial, regular check-ins, symptom monitoring, empathetic clinicians, may itself function as a therapeutic intervention. Depression is a condition particularly responsive to context. Social isolation worsens it. Social support improves it. The regular, structured attention of a clinical trial, where someone asks you every 2 weeks how you're feeling and listens carefully to the answer, may provide exactly the kind of social engagement that depressed patients lack in their daily lives. Different cultures show different patterns of placebo response. This has been documented in multinational drug trials. Placebo response rates for the same condition can differ by 10 or 20 percentage points between countries. Some of this variation may reflect differences in how symptoms are reported or measured, but some appears to reflect genuine differences in how the brain responds to treatment context. In some regions, injection placebos produce stronger effects than pill placebos. In others, the pattern reverses. Cultural expectations about what constitutes real medicine shape which placebo form the brain finds most convincing. In cultures where injections are associated with powerful treatment, an injection placebo activates the brain more strongly. In cultures where pills are the dominant form of medicine, pill placebos are more effective. Germany has consistently shown higher placebo response rates in gastric ulcer trials compared to other countries. Brazil has shown high placebo response rates in certain pain conditions. These differences are not easily explained by genetics alone. They likely reflect cultural attitudes toward medicine, doctor-patient relationships, and the meaning assigned to treatment rituals. But genetics do play a role. The COMT gene encodes an enzyme called catecholomethyltransferase, which breaks down dopamine, norepinephrine, and epinephrine in the prefrontal cortex. Different variants of this gene, called polymorphisms, result in different rates of dopamine metabolism. People with the MET-MET variant of the COMT gene metabolize dopamine more slowly, leading to higher dopamine levels in the prefrontal cortex. And these individuals tend to show stronger placebo responses. They respond more robustly to the expectation of benefit. Their brains produce a larger dopamine signal in response to a placebo. People with the VAL-VAL variant metabolize dopamine more quickly and tend to show weaker placebo responses. Their brains clear dopamine faster, producing a smaller and shorter-lived expectation signal. This means that placebo responsiveness is partly heritable. It has a biological basis. Some people are genetically predisposed to stronger placebo responses. This is not a personality trait. It's not about gullibility or suggestibility. It's about how quickly an enzyme clears dopamine from the prefrontal cortex. Catherine Hall, a researcher at Harvard, has called for the development of a placebo, a map of the genetic variants that influence placebo and nocebo responsiveness. She argues that understanding a patient's placebo genetics could improve clinical trial design and even guide treatment decisions. Conditioned placebo responses can be established for immune function. This goes beyond pain and mood. Researchers at the University of Duisburg-Essen in Germany conducted experiments where healthy volunteers drank a distinctively flavored green liquid paired with cyclosporin A, an immunosuppressant. After several pairings, drink the liquid, take the drug. The drink alone suppressed immune markers. Interleukin-2 production dropped. T-cell proliferation decreased. The body had learned to associate a taste with immune suppression. This has profound implications. It suggests that conditioning could potentially be used to reduce the dose of immunosuppressive drugs in transplant patients. If part of the immune suppression can be maintained through a conditioned stimulus, a specific drink, taken at a specific time, then perhaps the drug dose could be lowered, reducing side effects while maintaining therapeutic effect. This idea is still being tested, but early results are promising. Placebo responses appear in children as well, and they tend to be stronger in children than in adults. Pediatric clinical trials for conditions like ADHD and depression often show high placebo response rates, making it difficult to demonstrate drug efficacy. Children may be more responsive to the social and ritual elements of treatment. The attention of a doctor, the structure of a treatment plan, the reassurance of a parent. Placebo responses have been documented in animals, though the mechanism is purely conditioning, not expectation. Rats that have been repeatedly given morphine in a specific environment show pain reduction when placed in that environment without morphine. They don't expect morphine. Their nervous systems have formed an association between the environment and opioid release, and that association triggers a physiological response. This tells us something about the layers of the placebo effect. The oldest layer, conditioning, doesn't require consciousness, belief, or language. It runs on simple association, the same mechanism present in every animal with a nervous system. The newer layer, expectation, requires a prefrontal cortex capable of modeling the future and generating predictions. This layer is much stronger in humans, and it interacts with the conditioning layer, sometimes amplifying it, sometimes overriding it. The placebo effect varies across medical conditions. It is generally strong in conditions with a large subjective component: pain, depression, anxiety, fatigue, irritable bowel syndrome, nausea. It is weaker in conditions defined by objective biological markers: tumor size, viral load, bone fracture healing. But even in conditions with objective markers, placebo effects have been observed. They tend to be smaller and less reliable, but they exist. In Parkinson's disease, placebo effects are robust because the disease involves the dopamine system, the same system that generates expectation signals. In chronic pain, placebo effects are strong because pain has both sensory and affective components, and the placebo can modulate the affective component through descending inhibitory pathways. In depression, placebo effects are strong because mood regulation involves prefrontal circuits that are directly engaged by treatment expectations. The placebo effect tends to grow stronger with repeated administration. The first dose of a placebo may produce a modest response. By the fourth or fifth dose, the response may be larger as conditioning effects accumulate. Each positive experience, taking the pill, feeling slightly better, reinforces the brain's prediction that the pill works. But placebos can also show tolerance effects, similar to real drugs. Over very long administration periods, the placebo response may diminish as the brain recalibrates its expectations. This hasn't been studied as extensively as tolerance to active drugs, but preliminary evidence suggests the phenomenon exists. The time course of placebo responses often mirrors the expected time course of the drug being mimicked. If patients are told a medication takes 2 weeks to start working, the placebo response often begins at around 2 weeks. If they're told it works within an hour, the placebo response begins within an hour. The brain doesn't just predict that relief will come. It predicts when relief will come and adjusts its timing accordingly. This is one of the most striking details in the entire placebo literature. The brain models not just the magnitude of expected change, but its temporal profile. It generates a time-stamped prediction and then adjusts the body's physiology to match that prediction on schedule. Pain research has revealed an additional layer, the concept of placebo responders and non-responders. In any given study, not everyone responds to the placebo. Some people show robust responses, others show none. Early researchers assumed this was random, but longitudinal studies suggest that some individuals consistently respond to placebos across multiple studies and conditions, while others consistently do not. This consistency supports the genetic hypothesis. If placebo responsiveness were random noise, you wouldn't expect the same people to respond every time. But if it reflects stable biological differences, enzyme levels, receptor densities, prefrontal cortex activity, then consistency is exactly what you'd predict. Personality traits have been explored as predictors of placebo response, but the results are mixed. Early studies suggested that suggestible, agreeable, or optimistic people might respond more strongly to placebos. But subsequent research found that these correlations were weak and inconsistent. The genetic markers, particularly COMT polymorphisms, are stronger and more reliable predictors than personality questionnaires. Here's the thing. This challenges the common assumption that placebo responders are somehow more gullible or less rational than non-responders. They aren't thinking differently. Their brains are processing dopamine differently. It's an enzymatic difference, not a cognitive one. The placebo effect has been a source of frustration for drug developers for decades. A drug must outperform its placebo to earn approval. As placebo responses rise, especially in psychiatric trials, the gap narrows. Drugs that genuinely work may fail to reach statistical significance, not because they're ineffective, but because the placebo arm performs so well. Some pharmaceutical companies have responded by trying to screen out strong placebo responders during the initial phase of a trial. This is controversial. It may produce cleaner data, but it raises the question of whether the drug will work as well in the general population, which includes placebo responders. Others have turned to different trial designs, using active comparators instead of placebos, or using placebo run-in periods where all patients receive placebo first, and only those who don't respond are randomized to the drug or continued placebo. These methods have their own limitations and critics. The deeper question is whether the placebo effect is a nuisance to be eliminated from clinical data, or a therapeutic tool to be understood and used. A growing number of researchers argue for the latter. If the ritual of care, the warmth of a clinician, the framing of treatment information, and the structure of a treatment plan all contribute to healing, why not optimize these elements alongside pharmacological treatment? Why not train clinicians in the art of enhancing placebo responses through communication, empathy, and appropriate expectation setting? This is not the same as deceiving patients. It's about recognizing that the context of treatment is itself a treatment. We've now traveled through history, chemistry, the body's responses, the nocebo's shadow, the surprise of open-label placebos, and the cultural and genetic landscape of belief-driven healing. The final group of facts looks at the quiet architecture that underlies all of these observations. The placebo effect is not an anomaly. It is not a bug in the system. It is a window into how the brain operates at the most fundamental level. The brain is a prediction machine. This is not a metaphor. It is a description of the organ's primary function. The brain does not sit passively, waiting for signals from the body and the world. It actively generates predictions about what will happen next, and then compares those predictions against incoming sensory data. When the predictions match, the system runs smoothly. When they don't match, the brain updates its model. This process, prediction, comparison, correction, runs continuously below the level of conscious awareness across every system in the body. The placebo effect is what happens when the brain's prediction of improvement is strong enough to alter the body's physiology to match. The brain predicts less pain, and it reduces pain signals. It predicts calmer breathing, and it adjusts the experience of respiration. It predicts healing, and it mobilizes immune resources and anti-inflammatory pathways. This is not unlimited. The brain cannot predict away a tumor. It cannot regenerate a severed nerve through expectation. The placebo effect operates within the body's existing physiological capacity. It modulates systems that are already in place: pain suppression, immune regulation, autonomic function. It turns dials that the body has. It doesn't install new dials. But within those constraints, the effect is real, specific, and sometimes large. Carl Friston, a neuroscientist at University College London, has proposed a framework called the free energy principle, which describes the brain as an organ that constantly works to minimize the difference between its predictions and its sensory inputs. Under this framework, the placebo effect is not surprising at all. It is the expected behavior of a brain that has received strong predictive information. You are going to feel better, and is now adjusting its internal state to bring reality in line with that prediction. The interoceptive system, the brain's representation of the body's internal state, is central to this process. The insular cortex receives signals about heart rate, blood pressure, gut motility, respiration, temperature, and inflammation status. It constructs a map of how the body feels right now. And the prefrontal cortex sends top-down predictions to the insula about how the body should feel. When you take a placebo you believe is a painkiller, the prefrontal cortex sends a prediction to the insula. Pain is decreasing. The insula adjusts its representation, and the subjective experience of pain changes. This is the same system that allows you to feel comfortable in a cold room when you know the heater is about to turn on. The knowledge, the expectation, changes the experience before the physical conditions change. The prediction modifies the perception. Sleep operates on closely related circuits. As evening arrives, the brain begins assembling cues, diminishing light, decreasing activity, habitual routines, and generates a prediction. Sleep is approaching. Based on that prediction, it initiates a cascade of physiological changes. Core body temperature drops. Melatonin secretion increases from the pineal gland. Heart rate slows. Muscle tone decreases. The brain shifts from externally focused processing to internally focused maintenance. These changes happen because the brain expects them to happen. The routine, the darkened room, the familiar pillow, These are cues that the prediction system uses to initialize the sleep sequence. If you disrupt the cues, bright lights, unfamiliar environment, unexpected noise, the prediction weakens, and sleep becomes harder to achieve. The prefrontal cortex, so active during waking placebo responses, gradually quiets as sleep approaches. Its predictive role diminishes. The executive control that generates expectations and plans and models of the future slowly releases its grip. The brain shifts from a mode of active prediction to a mode of passive restoration. And as the prefrontal cortex quiets, a different kind of processing takes over. The default mode network, a collection of brain regions active during rest, mind wandering, and the early stages of sleep, begins to dominate. This network is involved in autobiographical memory, self-referential thought, and the kind of loose, associative thinking that characterizes the moments before sleep. The transition from wakefulness to sleep is, in a sense, a transition from one kind of brain state to another. The waking brain makes explicit predictions and tests them against reality. The sleeping brain lets go of prediction and allows the body's repair systems to work without oversight. During slow-wave sleep, the deepest stage growth hormone is released from the pituitary gland. Tissue repair accelerates. The glymphatic system, a waste clearance mechanism in the brain, opens channels between cells and flushes out metabolic byproducts that accumulated during the day. Amyloid beta, a protein associated with Alzheimer's disease, is cleared during sleep at rates much higher than during wakefulness. The immune system reorganizes during sleep. Certain immune cells, T cells, and natural killer cells show different activity patterns during sleep than during waking. Pro-inflammatory cytokines, which help fight infection, are released in greater quantities during sleep. This is why you feel sleepy when you're sick. The brain is pulling you toward the state where immune function is strongest. And this happens every night, without instruction, without medication, without conscious effort. The brain monitors its own state, generates predictions about the need for repair, and initiates the processes required. The body's capacity to regulate itself in response to context and expectation has been present for as long as nervous systems have existed. Simple organisms, flatworms, roundworms, sea slugs, show conditioned physiological responses. They learn that a stimulus predicts an event and they adjust their internal state in advance. This is the root of the placebo effect. Not belief exactly, not conscious expectation, but the basic biological capacity to use information about the environment to prepare the body for what comes next. Over hundreds of millions of years, this system has grown more sophisticated. In mammals, it includes cortical processing, emotional modulation, social signals, and language. In humans, it includes abstract belief, narrative understanding, cultural context, and the ability to be changed by a sentence spoken by a person in a white coat. But underneath all of that complexity, the mechanism is the same. Information from the environment enters the brain. The brain generates a prediction. The body adjusts. A sugar pill is information. A doctor's reassurance is information. A branded package is information. A warm hand on a shoulder is information. And the brain responds to information the way it responds to everything, by updating its model and adjusting the body to match. Tonight, as your body settles toward rest, your brain is already making predictions. It senses the stillness of the room. It registers the weight of the blanket. It notices the slowing rhythm of your breathing. Based on these cues, these small, quiet signals, it begins to prepare. Core temperature drifts downward. Muscles release their tension, fiber by fiber. The heart finds a slower pace. No pill was taken, no injection given, no treatment prescribed, just context, just expectation, just the oldest medicine the body has ever known. The quiet prediction that rest is near and that the body can safely let go. Billions of neurons coordinate this transition in silence. No single cell directs the process. No conscious thought is required. The system works the way it has worked for as long as brains have existed, reading the signals, building the model, and gently adjusting the body toward the state it expects to find. And so, slowly, the mind begins to quiet. The facts drift to the edges of awareness. The details soften. What remains is not a single observation, but a feeling, the gradual recognition that the boundary between mind and body was never a boundary at all. It is a loop, a continuous exchange of signals between what the brain believes and what the body does. And tonight, the loop is carrying you toward sleep. The same circuits that respond to placebos, the same prefrontal predictions, the same top-down signals, the same ancient capacity for self-regulation, are active now, guiding your body through the slow transition from waking to rest. There is nothing to do, nothing to decide. The process is older than language, older than medicine, older than the first human who looked up at the night sky and wondered what the stars were made of. Your body already knows how to do this. Let it.